All right, but I think we should probably get started and hope that others will sign in pretty quickly because I do want to state to the agenda and end by 4 Eastern Standard Time. I like to always stick to the agenda as best I can in terms of time frame. What I wanted to do with this little half hour of debriefing is just to see from the various breakout groups if there was anything that was, I mean, first of all, if there was a general agreement that most, if not all of the recommendations were sort of, that were in those draft form, we're still on target, if there are some that should be eliminated, if there are some gaps that we need to develop new things, a general sense of, are they going in the right direction of where we want to go? Recognizing that more work needs to be done. And what I hope will happen is that any notes that people took during the sessions, they could forward to me. And then I will also get some feedback from the note takers that were in each of the sessions. And then tonight and tomorrow morning, I will work to try to put them into another format to allow us to have a little bit more discussion tomorrow morning, and then have the work groups, our data work group, our equity work group, and our health systems work group, look at all of those recommendations from their specific perspective. Are we, are there some overriding data issues? Are there some overriding equity issues? Are there some overriding workforce or care system issues that need to be addressed, so that we slice the view of these recommendations from a couple of different things, one from topic focus and then one more from the work group focus. And so, and I know that a couple of the sessions, breakout groups had fewer recommendations, particularly the physical environment and the migrant health area, and that the COVID and the health systems one had, a lot more draft recommendations. So why don't we start with the physical environment? And I know that went fairly well. There was pretty general consensus there. So maybe Jean, you could fill us in on just general what you thought of that session and what you might suggest we think about moving forward with what was talked about there.
Sure. Did you want me to share the screen or just discuss broadly?
I think you can just talk, because there wasn't, I didn't see a whole lot of changes that were made from what was distributed earlier.
No, thank you very much. No, it was pretty straightforward. Everybody has the statements. We're going to rearrange it a little bit to make it look a little bit better. But Tara had a great recommendation that we provide the broad perspective. When we're talking about exposures to the environment, it's as important to realize, and historically we understand, that exposures may be as broad as and as inclusive as drugs, alcohol, tobacco, even I think from some of our perspectives, blood sugar for a woman with diabetes. So those are forms of toxic exposures. Much of the time, it's a choice, a personal choice about taking drugs, exposing to alcohol and tobacco, but it's also as expansive as toxic substances in the air we breathe, the water we drink, the food we eat, and the products that we're using. So in those circumstances, there's less of a choice without strong regulatory influences. So in the latter, we've got a mother and infant having very little means of timing or limiting their exposure to toxic chemicals because of life circumstances, demographics, social determinants of health. So we thought it was important to call out those, to address all of them, but then call out some of the differences there. And then it's the regulatory agencies that will protect health. And then we decided to flip the descriptions around and provide recommendations first and then background. So for example, we recommend that the Secretary of Health and Human Services commit and implement a major and sustained increase in research funding and policies aimed at protecting pregnant women and infants from harmful environmental exposures. And then we give the background based on the presentations that we had at our last visit. Our second recommendation is that we recommend that they Health and Human Services significantly expand and improve CDC's biomonitoring program, especially monitoring of pregnant women, infants, and children. And then we provide the background of where biomonitoring helps. Third recommendation is that Health and Human Services invest in, strengthen, and expand CDC collaboration with the EPA. So at this point, we're saying we've got our agencies that are important for regulatory and for research to implement, house, and maintain the most up-to-date data and better identify communities at risk so that we can invest and build upon America's Children and Environmental Indicators series. Next recommendation is that Health and Human Services direct the Food and Drug Administration to identify and eliminate all sources of lead in food, cosmetics, personal care products with lead and other toxic metals in baby food as a top priority, and coordinate with HUD and EPA to swiftly implement a multi-pronged nationwide strategy to eliminate all sources of lead. This one, I was saying, I think is absolutely critical because we know that there is no safe level of lead. So all of us should be able to voice that clearly, without doubt, and say, this is from a public health policy, we should make this, we should enforce this strategy, we should have it in all of our documents, and then say, EPA, HUD, everybody, it's up to you to make this happen. And they can figure out the logistics to that. And then let's see, we had a great recommendation that the Kellogg Foundation and others fund a science-based RFA that would complement the current Kellogg Racial Equity Program. And this came about that the Kellogg Foundation has a Racial Equity 2030 initiative to invest $90 million to fund bold solutions to drive an equitable future. We believe that this should be built upon with Health and Human Services funding so that it could complement what's going on. And then the final recommendation is that we recommend all infrastructure projects be implemented with a focus on equity and improving individual and community health. So again, all the things that we're hearing about, whether it's transportation, energy, sanitation, safe water, it gets back to the water we drink, the air we breathe, the food we consume, our life circumstances, or all the factors that are involved in social determinants of health. Those are going to have an impact on our populations. So making sure that the infrastructure focuses on safe health outcomes. So that's it in a nutshell.
Right. So the one thing that we need to get a little bit of work on is some recommendations, particularly related to alcohol, tobacco, and other drugs as environmental toxins. So we need to work on, because I agree that we need the broader physical environment recommendation, but also those chemicals that impact moms and babies. So that still needs to be worked on. Thanks. Comments from anybody else? All right.
Jeannie, on this one, when you're talking about you're looking for something on substance use and also you're looking for something around screening and treatment, or are you looking more broadly?
This is a broad, what I think we say is that when it comes to drugs, alcohol, tobacco, we actually have much more robust information. And I always put it when I'm talking with people, clinicians know that those are areas of concern, but having that be part of this broader discussion helps them understand that these are all types of toxic substances. So that whether we're talking about drugs and alcohol, or we're talking about PFOA and lead, those are all in the same boat of toxic substances. On the one hand, we're pretty familiar with drugs, alcohol, and tobacco. And on the other hand, we're not so familiar with these, but we should put them all together.
Well,
Does that help?
And they might compound each other too. So I think that's
Clearly,
interesting.
yes.
I think that's so that
Yeah.
hopefully that will come out of the research as well.
Yeah.
So we need to do a little bit of work on, because Belinda, this is a big broad range of things that you can work on, all the way from education to marketing techniques and public policy related to price and all of those things. So we have to, I think we need to narrow it somewhat and so we'll do some work. We need to do some work on trying to clarify that.
Well, and there is good research out of California with the Early Start program that shows you can decrease infant mortality and complications with a concerted effort on drug and alcohol and tobacco programs. So we've got very good data on early start.
Yeah. Okay, oh,
Yeah.
good.
Thank you.
All right. And I don't see Paul Weiss on here. That was the other breakout group that had a fewer number, but Janelle and Colleen and Belinda were on that one. What was the tone of the conversation there with the border health and migrant health?
Oh, sorry, just before we move on, Jeannie,
Yeah.
in your discussion, did anyone bring up just the safeguard and establishment of clean water throughout the US for all people?
Well, yes, in the sense that that's one of the four, it's the air we breathe, the water we drink, and calling on the EPA. We focused in the one sense on lead, but clearly the PFOAs and the information that's coming out on our water systems is critical. So yeah, air, water.
Right, so
Food.
some strong language about that, just, given that, 10, 20 years, that, we could potentially look very different and disparities could be even graver than with access to clean water, knowing that we have communities today that lack access to clean water, clean, healthy drinking water. So it'd be lovely to have stronger language on that, safeguarding it. And as I've said before in other work groups, water is a commodity that we can buy on the New York Stock Exchange. That just happened, a few months ago. So it shows you that it is a commodity that is being betted against.
Not a public good or a right. It's a
Right.
good.
And we've got such good research that's come out of Irvine, California, that an investment of, I think, what is it, $32 per person, which is certainly less than a lot of people spend on their water, you can have an absolutely clean and safe water supply. So we've got research that shows the potential. It's just that potential isn't realized.
All right, we got to move along here.
Yep.
Paul, you are on. Good. What was the feedback or the sense from your group?
I apologize. I'm sorry.
Paul Weiss.
Sorry, Paul Jarvis.
You win again.
Sorry for getting on late. A few technical issues getting into the room. Well, there was general agreement on the proposed recommendations. However, there were several different areas suggested for expanding the recommendations, particularly to ensure that people recognize the social services, reunification services, and mental health services that are going to be required for the children of families, pregnant women coming through the system. It was also important to recognize that services should be provided to all migrant families, not just those recently released at the border, that there's a broader need for provision of access to services to a wider community, that community partners and institutions should be engaged to help ensure access to these groups. There was also a suggestion that for those families who were caught up in the zero tolerance program, in which children were separated from their parents, there are approximately 7,000 estimated to have been separated, that HHS address their needs by providing appropriate mental health and social services for families that were in fact separated by the US government during zero tolerance. And the last was to recognize the special challenge of COVID, and particularly the provision of vaccines when the approval for vaccines for young adults and children are appropriate and embraced by local public health authorities. Let me stop there and see if anybody in the group correct my mistakes or make additional comments.
All right, so it sounds like there was a good consensus of the direction that you're going in. So if you could send me, whatever notes you had from your group, then I'll put those into a document tonight, and then we can have a more exhaustive conversation tomorrow afternoon when we get together to have the an extended conversation. So thanks.
Thank you.
All right, any other comments from the rest of the team or questions? All right, then let's go to the other Paul, Jairus.
Okay, happy to be the other Paul to Paul Weiss. So basically with the COVID-19 recommendations, there's two general ways of looking at it. One are recommendations specific to COVID-19, and the other is to address those systemic gaps that we have in our system that were stressed by COVID-19 and became more apparent or quite apparent. So in particular, with regard to COVID-19, making sure that asking the Secretary to pay particular attention to pregnant women, lactating women, and infants regarding harm to their well-being. And that would include making sure that that these populations are priority populations and are considered in all the policies going forward, including educational materials, support materials that are culturally appropriate, and in particular community-based to reach groups that otherwise were at greatest risk or vulnerable. Ensuring that there's a full workforce that is educated and capable to support these individuals through COVID-19, as well, of course, in many other areas. The telehealth has become quite apparent tool. We want to make sure that the whole comprehensive healthcare, public health, and social support system is intact, and that telehealth is looked at within this context to see where it can particularly enhance the care of other systems and providers during a challenge like infectious disease and COVID-19. With regard to what we would say at any point, but is even more clear now, is that recommending that Medicaid finance birth for a minimum of 1 year after the end of pregnancy, or we use the word end of pregnancy. And we use the term end of pregnancy rather than delivery to be a little more inclusive of women who might have a poor pregnancy outcome, to assure that they had care, as well as those who go to delivery. And making sure that we have, as part of this comprehensive system, looking at enhancing the telehealth services, such as appropriate monitoring tools that can be used by pregnant women, infants, and others postpartum, so that if they do receive their services remotely, they have other tools that are necessary. A lot of conversation on data and surveillance systems and the challenge of setting these up with regard to COVID-19 and pregnancy, as well as COVID-19 pregnancy and underrepresented or disproportionately impacted groups, and the need to strengthen those systems and the interoperability of those systems. We also thought it was important, whenever possibly, consistent with recommendations from the OMH COVID-19 Equity Task Force or the American Recovery and Expansion Act, Recovery and ARRA, I apologize, spacing. I think those were the major things, but I would like to ask the group for additions, subtractions, or corrections.
It seemed to cover it from the perspective that, because I was in that group. Yeah.
Thank you.
All right, and then Steve Calvin from the Workforce and Systems of Care. You had a couple of different areas to focus on.
We did. Yeah, we did, and some of it overlapped with Paul Jairus's group, so that was helpful. I'll just make the quick comments, and I sent you a copy with comments in red. When addressing the accredited birth center option, it was pointed out that it should just be as an option within a comprehensive system of care, which makes a lot of sense. There were comments about in expanding and sustaining the public health workforce. Michael Warren made a really good point that workforce development efforts should be really mindful of what happened about 100 years ago, when there was kind of like a care improvement initiative that essentially eradicated or ended up stopping the practice of traditional midwives, especially in the South, mostly Black. They were removed from their communities as a practitioner under the guise of improvement of care. So I just think we have to be really mindful of that. Probably when we're even talking about doula services and, trying to strike a balance between adequate training, but not making things so rigid and so just kind of unthinking that we end up actually doing some harm. Colleen also recommended that we spend some time looking at training and availability and support for neonatal nurse practitioners, because for midwives and neonatal nurse practitioners, there aren't enough training programs, and there's a shortage around the country. Fast forwarding here, related to doula services, and I know Ed, you have done a lot of work with Mina and the, putting together a bibliography. Rachel from ACOG asked that there be citations regarding, the outcomes under recommendations related to doula services about improvements of outcomes. And I know we have that. And I think there was some discomfort about specific recommendations, the ones listed below, about, the USPSTF. And I'd be interested too. And, Jean, you have, as kind of a founding leader of the WPSI, the Women's Preventive Services Initiative. Anyway, I just wanted to pass along that I think from an official standpoint, ACOG is a little nervous about kind of a huge push to suddenly have doula services available with all these recommendations. I think we just need to talk about it more tomorrow. And then finally, Belinda brought up a really good point that as we recommend expansion of services and have kind of wish lists of things, I think we saw this in we listened to Merlin and to Afua, that we should really focus on expanding the current Healthy Start program, since it really does address health equity and has all along. And with that, that's all I have.
Excellent. Other comments? Yeah, I anticipated that there might be some discomfort with doulas. That's why I didn't say, that's why I said the United States Preventive Services Task Force should evaluate their doulas in terms of a preventive service, recognizing that they have their own process. The same thing with the WPSI, evaluate them as a preventive service.
Do you want comment now or tomorrow?
I think tomorrow will be
Okay.
good, because then we can put it in broader context.
Yeah, there's a difference between service and who is providing it.
Yeah.
Okay.
Yeah. So yeah, we don't have time for, it's a longer conversation. That's why I built it in for tomorrow. I figured there'd be some, various perspectives on it and details that need to be worked out. Anything else any questions from the other members of the team related to the workforce and health systems? All right. So what I would like is if the leads from those breakout groups, if you could send me, and I think some of you are already done it, send you the notes from that. I will try to, over the next 12 hours, put that into another format and another draft to get out to you so that we can have a conversation tomorrow. And then I will from that have the work groups look at each of the total set of recommendations from their various perspectives, from equity, to make sure that make sure that we're centering on equity with all of that work, that we've got the right data, and that our systems approach and workforce is comprehensive enough to meet those needs. And then we can figure out the next steps of how to move forward after that. All right, anything else that we need to talk about today before we take our break and come back tomorrow afternoon or morning, depending on your time zone? Vanessa, anything? Michael, Dr. Warren, or Lee?
So nothing on my end.
All right. All right, then we'll meet again at noon Eastern Daylight Time tomorrow, and we'll go from there.
Thanks, Ed.
Take
Thank
care.
you. Thank you.
Thank you, Ed.
Bye-bye.